so we're going to use the real names, right? We're going to call them by their names. So this is Streptococcus pyogenes. But yeah, just when you see GAS and in the context of a strep infection, that is Streptococcus pyogenes. Growing in very long chains. So here's a cartoon of the bacterium, and the big thing to remember about this is the M protein, and that's one of these little spiky, one of these little spiky structures right there, the red spiky structure. That's your M protein. Here's another cartoon of that, and we'll come back to why that's important in just a minute. Because here's the punchline. This is the reason that we have rheumatic fever. We talked maybe just very, very briefly about rheumatic fever in immunology. It's an immunological disease because of cross-reactivity with the M protein. There's a teaser for about 3 slides from now. Just like we saw with Staph aureus, you've got different types of disease, those suppurative diseases, like a classic example there, strep throat, toxin-mediated diseases, and then your immune-mediated diseases, which predominantly, the only one that we'll spend just a moment on is rheumatic fever. Diagnosis of this for strep pyogenes, we've got that rapid strep test. And so now we're looking for antibodies against these carbohydrates on the cell wall, or those group A specific carbohydrates. All right, that can be done right there at bedside, there in the clinic. And then, you're probably going to confirm that. Yeah, you'll go ahead and give prescription to the patient before they leave if they've got strep throat. But then typically you'll confirm that through your biochemical testing. And yeah, I'm putting treatment on here just so you know things that can be treated or not, but are we going to talk about them? Am I going to test them on you? No. Okay. All right, so virulence factors, yes, we've got that capsule. A lot of the bacteria have a capsule for the bacteria that is often their primary virulence factor because it's anti-phagocytic. Remember, the neutrophils, the phagocytes can't grab onto those sugars very easily. For strep pyogenes, the M protein is a major virulence factor because number one, it attaches. So that is what helps the bacteria to stick there in the throat to now cause that localized suppurative infection of strep throat or streptococcal pharyngitis. All right, but now it's also going to help with the invasion. So for some of the diseases we'll see, we're getting not just there on the surface of the epithelial layer, but we're getting invasive disease. The M protein helps mediate that process. Excuse me. Okay, and then we've got several different exotoxins that are made there, and we'll talk about a couple of those when we talk about the diseases. Okay, so first we have our pyogenic diseases. Pyogenic, here we can sort of think of them as suppurative. Pyo because they're causing a fever. They're causing a fever because of a great cytokine response, a great neutrophil response, all of those typical inflammatory things that we're thinking about. Okay, and impetigo. You're like, Dr. Johnson, you said that was a disease caused by Staph aureus. Well, yes, it is. It's the same disease process, and so that's how we named them. Way before we could grow the bacteria and realize that there were 2 different ones, we had this disease called hepatitis. Where did that come from? Thinking about classic example. There are 5 different hepatitis viruses, but we call the disease hepatitis. Same thing here. I always go to the viruses. That's just who I am. Same thing here. It's one disease. It's impetigo, but it can be caused by 2 different bacteria. Sometimes by themselves. Often it can be a co-infection or an infection with that staph, that strep, and something else. Okay. But again, you see these pustular lesions. It'll be a little blister that then erupts, and when it becomes that scabby, you can see kind of that honey crust. That's just the serous fluid leaking out of that damaged skin and now crusting over as it basically dries out, causing those honey crusted lesions. That is a buzzy word. As soon as you see something with a little kid, this most often occurs in the kids 7 and under, that honey crusted lesions, especially around the mouth, upper body, that's impetigo, and that is your bacterial infection, right? Whether it's staph, whether it's strep, okay? If it's staph aureus. If it's strep pyogenes, right? Then we have erysipelas, and that's what you see with this gentleman. And so now, instead of being right there on the skin layer, this is going just a little bit deeper into the skin, more into the subcutaneous tissue. All right. So a specialized form of cellulitis that we talked about with Staph aureus. Okay? Very often occurring on the face and on the limbs. All right. And then we have cellulitis. So this is deep tissue. So this is just sort of gradients as you're working down from the surface into more of the subcutaneous, and then with cellulitis in the deeper tissue. But again, the same process is occurring. Right? Then you have diseases that aren't, ones we talked about on the last slide were purely pyogenic. Okay? Now we have ones that can be a combination. Okay, so the strep throat is pyogenic, yes, but now that strep throat, if it's not treated, can cause scarlet fever if that strain of Strep pyogenes is now secreting this specific toxin. Yeah, it's in Burgundy, but I'll give you this. You don't need to know that it is the erythrogenic toxin. Okay, so you develop here. You have your strep throat. Okay, and so here are really red, inflamed, beefy red. All of this inflammation into oropharynx. Here's your exudative. See those little yellow streaks? That's pus on the tonsils. Okay, that's the bacteria. That's the neutrophil. All right, all of that at work there. All right, that's your pustule, your purulent tonsillar exudate for medical description. All right, and then if it's even if it's treated, because this can happen within a few days of the onset of that strep throat, now you've got the toxin that's being made by the bacteria here in the throat, but that toxin, this erythrogenic toxin, is going throughout the body. And so now you develop this rash, but it's not just a smooth rash, it's bumpy, feels just like sandpaper. And so that's why it's called a sandpaper rash. That is especially on the chest, and because it's the toxin disseminating down, so you're thinking more upper body, and then it can go to the lower limbs, but here you're really thinking about face and upper body. Okay, but also another thing, strawberry tongue. All right, here's your strawberry tongue. Because of all the inflammation, all the toxigenic activity, here's your little red strawberry with a little of the tongue, and then all the papillae, all your taste buds are raised there, and they're white. They're not getting the circulation, they're not getting the toxin, so they don't turn that edematous red color. All right. And then we have rheumatic fever, and this is the inflammatory. So here's the process: you get infected with Streptococcus pyogenes. You start taking your antibiotic, or maybe you just have a sore throat, but it's flu season. Mom, dad, parent, caregiver, whoever. You as a little kid think, you just got the flu because I just had the flu and you can't do anything about it, so we're just going to stay home. You don't, bottom line, you don't go get that prescription. Or you do get the prescription, but you as a bratty little kid say, I feel better 3 days later. I don't need to take the rest of that nasty drug. All right? Yeah, it tastes terrible. You don't finish your prescription. 6 months later, 3 months later, your joints start hurting. 6 months later, your heart starts doing all this little fluttering thing in your chest. That's rheumatic fever. What's the pathogenic process here? You didn't finish your antibiotic, so you still had a lot of bacteria floating around in your throat. Enough that you make a really good antibody response, especially to that M protein. Right? That M protein, just by happenstance, looks a whole lot like a myofibril M protein that's in the joint, but is expressed at very high levels in the heart. Now you've got that antibody that was made to the M protein of Strep pyogenes that is going to bind to those proteins in the joint, bind to that protein in the heart. Now we have that binding. You get activation of complement. You get all of those things that we talked about in immunology. And now you have tissue destruction through that antibody-mediated process. A type 2 hypersensitivity reaction, right? Yep. I saw at least one person nod ahead there. So yeah, that's the process. You're not infecting that heart tissue. You're not infecting the joint, but you've got that antigenic mimicry going on, so the antibody recognizes the self protein and binds. That's rheumatic fever. It all happens when you don't take or don't finish the antibiotic, and now you have enough time for the body to make a great antibody response. We have very low levels of rheumatic fever in most developed countries now because, everybody loves their antibiotics, and at least used to, they would take them all. This is still a significant problem in developing countries, and it's becoming more of a recurring problem because people aren't taking all of their antibiotics anymore. All right. Yes?
Can you do anything to neutralize that later, or you just live with that?
Can you do anything to neutralize that later? So you can treat the rheumatic fever, but it's mainly just managing the inflammation. You can't get rid of those antibodies. So eventually those memory B cells will die off. But yes, it can be an ongoing problem for a while. All right, toxigenic diseases. And so here, classic example of this are the flesh-eating bacteria. Streptococcal gangrene, here's your picture. And this is where you have secretion of two specific toxins, the streptolysin A and O. And so you'll see those. The infection can be anywhere in the body, but now it's typically here in the tissue because you're having such high level of damage. But then the toxin, it may be just at one specific focus. You've got that puncture wound, you've got that wound that is just right here, or maybe right here on his wrist, but now you've got all of this tissue damage because the toxins are being made and then they are distributed. They enter the circulation, but more importantly, they're now being secreted into all of the different planes of fascia and the muscle, not the striation because that's in a single muscle fiber, but between all of the planes of tissue. So think about a layer cake. You've got the layers of the tissue, and that icing would be between all of your layers, or it's going to be the toxin secreted in. Now the cake gets mushy if you've got lots of icing, right? That's the tissue destruction that's occurring with these diseases, all right? So especially with the necrotizing fasciitis, that flesh-eating bacteria. Streptococcal toxic shock syndrome, different toxins. Here, the streptolysin A and O, as the name tells you, that's direct tissue damage because the toxins are lysing the cells. The SPE and A and C, the pyrogenic toxins are super antigens. So this is all immune mediated because of the cytokine storm that is now generated. Okay. All right. Diagnosis of this. So going back to how do you identify it? So you do your gram stain. You've got your gram-positive coccus. That is catalase negative, so we know it has to be a strep, but which strep is it? It's going to be beta hemolytic, and so this is the major beta hemolytic. It's not the only one, but it's just because of the amount of disease that's caused. Whoops. Ooh. And then again, antibiotic sensitivity with the bacitracin. Okay. We'll skip the peer point to move on. Next one, Streptococcus pneumoniae. So this is one that, yes, it doesn't have a Lancefield grouping, and it does form chains, but this is a chain of two. So most often you're going to see these as diplococci, as a pair together. This is a classic description. It can be kind of hard to see, especially for the bacteria that are grown, that you see in a patient sample. But it's called, you have this lancet shape. So think about the lance of a spear and that pointed area. This is also an image that you see frequently. So it's this tip. And so most often it's just on one of the pair, it's not on both of them, but that is another big sign. The only time you see this, that lancet, that pointed end on a pair is when it is strep pneumoniae. Okay? So it does have a capsule. Even though it doesn't have a Lancefield grouping, we can make an antibody response to these capsules. Just doesn't work for the Lancefield assay for whatever reason. And this is the way that we can now serotype. So we know which strain of bacteria is causing the pneumonia in that patient. Or, jumping ahead to this last bullet, that's how we can make the vaccines. Okay, and so the different pneumonia vaccines, So the Pneumovax, there's the 15, 22, 32, I think 23, I don't think there's a 32, a little bit of dyslexia there. So those numbers are the numbers of carbohydrate, different capsule carbohydrates, because there's hundreds of different capsule antigens there, different serotypes. The numbers, the 15, the 22, the, whatever the number is on that Pneumovax vaccine is the number of serotypes that vaccine will protect against. So the Pneumovax 15 contains the capsular antigen of 15 different serotypes, right? The 22 has 22 different serotypes, right? So that's how we now can, and it's the 22 most common circulating in adults or in pediatric. Different vaccines for different age groups and different use. Won't talk about that level of detail. There's a little bit of information in the notes section, but again, that's just so you can understand the vaccines, not anything that would be testable. All right. Another important point, and so this is one of the differentiation tests. Instead of using an Optogen is an antibiotic, we don't use it clinically anymore, but that is an antibiotic test. So again, we're looking for sensitivity there. And MOPS, that is a buzzword. Two buzzwords for thinking about strep pneumo. One is MOPS, it's most Optogen sensitive, but you can also use that to think about what are the major diseases that strep pneumoniae causes. Yes, it's causing otitis media, one of the most common causes. It's also causing meningitis in adults, pneumonia, it does, that's what we all think about when we hear strep pneumoniae. And then sinusitis, it's the most common cause of sinusitis in kids, all right? And then we'll talk about the Quellin reaction here in a couple minutes. All right, so the virulence factors. So that rusty sputum, so when you have pneumonia and you're coughing up all that nasty, or even if it's not quite pneumonia, but it's close, you're coughing up that nasty sputum. You might see some little tinges of blood, but it's not gonna be really bright red, it'll be kind of rusty, okay? Because it's older blood, it's not fresh, it's been in the lung, it's been in that sputum sample long enough that it's starting to oxidize, all right? So that is being caused by this pneumolysin, as well as just the invasive nature. But the pneumolysin, it's lysine, so it's lysing those red cells. Lysing red cells means you're exposing, it's lysing the red cells, yes, but it's also lysing the epithelial cells. Lysing those epithelial cells in the tract means you're exposing the basement membrane. It's a tissue invasion. You can get a little bit of bleeding going on there in the respiratory tract. But it's very low level. It's kind of a seeping action. Drip, 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 not a gush, right? That is what now gives enough time that you've got rusty sputum. The reason I'm telling you at that level of detail is because of a bacterium that we'll talk about with the gram-negatives, where you've got bright red sputum, because now you've got severe damage and lots of gushing bleeding, relatively speaking, not the drip bleeding that we have with strep pneumoniae, okay? But that gives the rust-colored sputum. Another major protective factor is that IgA protease that is secreted by the bacterium, so now you have degradation of the IgA. So even if you're vaccinated, now you can have some susceptibility there, right? Another major factor is that capsule. Just like we've talked about before, that antiphagocytic, but the strep pneumo has a really major capsule, as we'll see in a couple slides. Epidemiology, this is all human to human transfer, no animals, no other reservoirs. So yes, we're colonized, but then it's all those respiratory secretions from either someone who is a carrier or someone who's infected and now infects you. We all are very susceptible, but the most severe disease we see in the really young and the really old, especially pneumonia. 4 major causes of pneumonia. It used to be 3, but now it's 4. And one of those is strep pneumoniae. So strep pneumoniae, it's in the notes, influenza virus, respiratory syncytial virus, and now we can add SARS to the list. Cause over 90% of the pneumonia worldwide. Leading cause of infectious deaths worldwide is pneumonia, and it's almost completely those 4 pathogens. Okay? But with strep pneumoniae, because we're colonized with the bacteria, you now have that influenza virus pneumonia, or even just an influenza virus infection if it's not pneumonia, and then you start feeling better, and 3 or 4 days later, now you've got a sinus infection. Now you've got that inner ear infection, the otitis media, because maybe it's the strep pneumoniae, maybe it's another bacterium that's causing that secondary infection. Those respiratory epithelial cells are damaged. That gives an open field for any of the colonizing bacteria to now cause clinically apparent disease. Okay? And transmission, if you're not colonized, almost half of us are, you're not colonized, it is now ingestion, typically inhalation, not ingestion, but it's acquisition, typically inhalation of those droplets from an infected person, from a carrier, into that respiratory tract. Clinical diseases, pneumonia, very classic pneumonia there. I will tell you if it's pneumonia. I'm not going to give you the signs and make you figure out that it's pneumonia, but there are the clinical findings if you want to read them. Or meningitis. Similarly, I will tell you if the patient has meningitis. I will tell you because we have to give the symptoms. They're presenting with a headache, with a stiff neck, with a fever. They're very classic symptoms of meningitis, but then I'll tell you that the physician diagnoses, or the nurse practitioner, whoever, diagnoses them with either pneumonia or meningitis. Okay? And then the next one is the otitis media. Okay? These are the 3 major diseases of strep pneumoniae. So diagnosis, yes, we've got our biochemical fingerprint. So we've got those gram-positive diplococci. They're alpha hemolytic. So alpha, remember that is the one that is a partial hemolysis. And so now, again, that streptolysin, it's going to lyse the red cells just like it's lysing those respiratory epithelium to give us that rusty colored sputum. But now, because you've just got a very weak lysis, relatively speaking, slow release of the hemoglobin, so there's time for it to be degraded, to be oxidized, and so it's going to turn green. It's not going to be that clearing, that complete lysis that you see with the beta hemolysis that we saw with strep pyogenes, right? Okay. Then we've got the encapsulation. So here is a stain, so you can see there that the diplococci in the middle, the 2 dark spots, and then that gray area around, that is your bacterial capsule. That's a nice healthy capsule, right? It's not just a little bitty covering. There's a thick capsule there. Great antiphagocytic response, all right? But this is also a way that we can now determine the serology, because you take an antibody to any of these capsular proteins. You put, capsular polysaccharides. You put that antibody on the bacterium, and then it's going to cause this swelling of the capsule. And so that's what you see here. Without the antibody, with the antibody. This is called the Quellen reaction. All right? Highly diagnostic. Number 1, to tell you that it's strep pneumoniae, because what antibodies are you using? They're specific for strep pneumoniae carbohydrates. But this is now allows you to determine if there's an outbreak setting. You go to a nursing home and there's an outbreak of Streptococcus pneumoniae, but everybody's been vaccinated. And you're like, well, what's going on here? So what you can do is you can test and see which serotype that strep pneumoniae is. And maybe it's one that's not covered by the vaccine. And so now you know that you have to monitor that population and monitor the community at large more closely, because, oh no, there is a strep pneumoniae bacterium circulating that isn't covered by our vaccine. Okay, so that's how you can use the Quellen reaction, not just for diagnostic, but for some really good, important epidemiology. All right. And then, so yeah, I was thinking it was the last slide, but here is, and again, some information in the footnotes, but the vaccines, because this can be prevented using the different vaccines that cover the different serotypes, and they're very highly effective. All right, real quick switch here. Okay, all right, so, yeah, knew I wouldn't be able to cover all of the strep in the last hour, but thought I'd at least get through those. Same algorithms here and here. So now we're going to talk about the rest of the strep. A couple more strep, and then we're going to talk about the gram-positive bacilli. So our group B strep, and again, and this is one that you'll hear even more. it is really difficult